All right, let's go to hyper and hypoparathyroidism. So quick anatomy review. I already described to you, these are the thyroid glands, and then here are the 4 parathyroid glands, located 2 on top and 2 below, behind the thyroid glands. Okay, let's start with hyper first, hyperparathyroidism. So this means the patient's parathyroid glands are hyperactive. The most common cause is a tumor. Now, so there's a tumor growing in any one of the parathyroid glands. Okay, it doesn't have to be, the tumor doesn't have to grow on all 4. It just needs to grow on one. So one or more of these grows a tumor. So that's enough to cause hyperparathyroidism. Now, this is one cause. Another cause of hyperparathyroidism is from chronic kidney disease. Remember CKD, ESKD, people on dialysis? So that's another cause of hyperparathyroidism. So they will develop hypercalcemia. Okay, so primary, again, it's usually caused by a tumor. So manifestations will be, what do you think will be signs and symptoms? These are all signs and symptoms of what? Since there's only one problem. These glands have one purpose, which is to produce calcium, parathyroid hormones. And there's only one job of the parathyroid gland, the parathyroid hormone, which is to do what? Produce calcium. Raise calcium level. So therefore, if you have hyperparathyroidism, what is the patient's main problem?
They have too much calcium.
Hypercalcemia. That's basically it. All the manifestations here are signs and symptoms of hypercalcemia. Okay. Oh, it's not limited there. We still have manifestations here. Okay, so it's quite long. From there to here are your manifestations of hypercalcemia. Where did this calcium come from, by the way? What caused the calcium to rise? Where did this calcium come from? Where do we have calcium in our body?
Our bones. Our bones.
Came from the bones and the teeth. So therefore, the high levels of parathyroid hormones cause the breakdown of calcium from the bones and the teeth. That's how it raises serum calcium. So it takes calcium from the bones and from the teeth, puts them into the bloodstream. Okay, and here are the resulting manifestations. Let's go straight to management. So how do we treat hyperparathyroidism? Well, it depends. What is the cause? If it's primary, what's the cause again? What's the cause again of primary?
Too much calcium.
Tumor. Okay, there's a tumor growing on the one or more parathyroid glands. So if there's a tumor involved, what do we do?
The tumor.
What do you do to a tumor?
You remove it.
Take it out on a date? You remove it. Okay, so surgical removal. So since we're talking about surgery here, will the surgery be any different or the same as thyroidectomy?
The risk factors, right?
Your nursing responsibilities.
The same.
Exactly the same. So we won't talk about that again. So we already discussed what the patient undergoing thyroidectomy will be, and the nursing responsibilities before and after surgery is exactly the same. Because why? Where are the parathyroid glands?
They're cutting the same stuff underneath the neck.
They're located or attached to the thyroid gland. So therefore, removal of the parathyroid glands results in removal partial or complete removal of the thyroid gland as well. Other interventions. So let's say the patient can't go to surgery yet. They're not stable. So what can we do with the hypercalcemia? What are there for the management of hypercalcemia? So these are the other options. Patient will be given lots of fluids. By mouth or intravenously, we will give them fluids. At the same time, the patient will also be given diuretics. But what type of diuretics? Anything but thiazide. No thiazide diuretics. Are we clear?
Yes.
Thiazide diuretics actually raise calcium because that's how they work. Okay, they decrease excretion, renal excretion of calcium. So you use diuretics together with fluids, but not what?
Thiazide diuretic.
Not thiazide diuretics. Mobility, you increase mobility. It's actually not good to place the patient on bed rest with hypercalcemia, because what will happen to the calcium levels if you put them on bed rest? It will get worse. It will get worse. Serum calcium will rise further if you put them on bed rest. So the more you put stress on the bone, then the more it will promote calcium deposition in the bone, meaning it strengthens the bone. So here's bones subjected to normal stress of walking give up less calcium. So this is the rationale why we don't put them on bed rest, because what does bed rest do?
It increases calcium.
It makes the condition worse. Diet, obviously, do we give them calcium or not?
No. If they have too much calcium, no.
Okay, very good. And because this will cause constipation, hypercalcemia will cause constipation. So what do? Give them
No softeners.
more increased fiber in the diet. The rest of the interventions are related to, yes, we promote activity, we promote mobility, but we also want to prevent falls, because if they fall, they will have what? Okay, they could sustain fractures. Okay. And this is a summary of your teachings for the patients with hyperparathyroidism or hypercalcemia. And complication, there's one, we call it hypercalcemic crisis. So this is a severely high serum calcium level. The normal is between 9 and 10. So this one is greater than 13. So this will result in severe neurovascular, cardiovascular, and kidney complications. So same treatment, however, we give the treatment in high amounts. So if we gave fluids here in hypercalcemic patients, then we give even more fluids in a hypercalcemic crisis. Rapid IV plus the diuretics at the same time. And then here's calcitonin. And we can also give biphosphonates. Remember osteoporosis in a previous semester? These drugs. What do you remember when we give biphosphonates? Because these are PO. What do you teach them to do when you give it? First of all, what time do we give it?
In the morning.
Early in the morning, empty stomach, or with food?
Empty stomach.
And what do we do after giving it on an empty stomach? We advise the patient to be in what position?
In a position.
An upright position. Okay, for how long?
30 minutes.
30 minutes to an hour. Okay, very good. So hypercalcemic crisis, they are at risk for severe dysrhythmias, so put them on a cardiac monitor. And besides calcitonin, you can also give steroids. That's about it. Questions on hyperparathyroidism? Very good, children. I think I can do hypoparathyroidism in under 10 minutes. So that's good. Okay. So hypoparathyroidism, the cause. There are several. One is vitamin D deficiency. Another is the iatrogenic, which was the surgical removal of the thyroid glands, which we discussed earlier. Or if they have hyperphosphatemia or kidney disease again. So kidney disease can cause havoc in calcium levels. It can either cause hyperparathyroidism or hypoparathyroidism. Manifestations, what are these manifestations of? Hypocalcemia. Okay. So if hyperparathyroidism is causing hypercalcemia, this one will be causing what? Hypocalcemia.
Hypo.
So severe hypocalcemia is called tetany. Remember these manifestations? Carpopedal spasm, what do we call this? That's called Trousseau sign. So carpopedal spasms is called Trousseau sign. When you put a tourniquet or a blood pressure cuff on the arm, it will cause carpopedal spasms. What about this one? What is Chivostix? Where will the spasms be?
In the face.
Face. Very good. Okay. Other manifestations are the following. So you've got, well, you have 2 paragraphs here. So here, don't do the ECG changes yet. We're not in module 8 yet, so you can do right up to there. Okay. Treatment. So your calcium is low. So what do we do?
Give calcium.
We give calcium. Very good. What is always given with calcium to promote absorption? Vitamin D. Very good. Now let's go to the vitamin D. Now vitamin D comes in 2 forms. We have activated vitamin D and then we have inactive vitamin D. Calcitriol is active vitamin D. Okay, calcitriol or L-gocalciferol, they are active forms of vitamin D. There is an inactive form of vitamin D, which is only reserved for chronic hypocalcemia or chronic hypoparathyroidism. For acute, we will give these. Okay. If it's severe and the patient is showing signs of tetany, which is severe hypocalcemia, we will have to give IV calcium gluconate. Okay. There's seizure precautions here because if you look under manifestations, this will cause seizures is mentioned somewhere right here. So hypocalcemia, especially severe hypocalcemia, causes cerebral edema, which leads to seizures or increased intracranial pressure. So we monitor them for seizures or institute seizure precautions. We'll discuss seizure in another section, although you did discuss seizures previously, right? In another semester, Research 1?
Yes.
Yes.
Okay. So you have an idea about seizure precautions. So non-pharmacologic interventions are you reduce the environmental stimulation to prevent seizures. Okay, so dim the lights, keep the noise down, okay, keep them comfortable. If the patient does have respiratory conditions, because they can because of the diaphragm. The diaphragm is affected here. Then we'll put them on a ventilator, or if not, we'll have to intubate the patient or maybe put a tracheostomy. Diet. Although we give high calcium diet, we also give low phosphorus. Now, what would be a good high calcium diet? And we give dairy?
Yes.
Actually, no.
No.
Here's the rationale. Thank you for reading, Ms. Caroline.
Although milk products, and egg yolk are high in calcium, they are restricted because they also contain high levels of phosphorus.
Okay, very good. So everything else that's high calcium should be okay. Another thing we avoid is spinach, and there's the rationale there. But we can give calcium salts and other sources of calcium except these. Okay?
Okay.
That would be it. And here's your summary. Okay, please read on your own. Very good. Select all and apply question. Any questions on hypo and hyperparathyroidism?